Okay, just another second and then we'll get started. All right, are there any questions before I start with today's material? Okay, we left off, we got a bit into chapter 22. We talked about some bacterial causes of infection, pneumonia. We are thinking respiratory tract infections. We also mentioned some upper tract, like Streptococcus pyogenes. And there were a handful of others that were all mentioned or talked about, at least in the tables that we left off with Wednesday. So shifting over, we want to think in this next little bit about some viral causes. And there are all sorts of potentials when we think about this. Deep down, I feel like we need a little update in this. I have been bombarded with some new textbook offers trying to, woo me into switching books because they've got coronavirus coverage. This came out, a few years before we were dealing with this pandemic. So I got no coronavirus in this chapter, but looking at this image, it is almost reminiscent of that. This is influenza, not coronavirus, but that's okay. So when we think about viral infections, the first, and respiratory tract, the first thing that pops into my mind as we think about all of the possibilities is something pretty simple, like the common cold. That's something that plagues lots of us. And as we think about this, signs and symptoms of the common cold, really pretty similar. There are numerous types of viral agents that can cause the common cold. Every time you get ill and have a common cold, it's a different type of viral culprit, right? Same idea when we think about influenza, and if you potentially have had multiple bouts of the flu, they're different strains, different varieties, if you will, that set the stage for causing illness. And in turn, with the influenza, that's why we see variation in flu vaccines from one season to the next. It's not the same, at least not at this point. They are definitely striving to come up with a universal vaccine for influenza. We're not at that point yet. So we'll see. I'm going to shift over to the textbook here in 1 second and talk a little bit about some similarities and differences between the cold and the flu here in 1 second. But as I've got influenza up here, the spikes on the surface of this virus are what we think the hemagglutinin and the neuraminidase, H and N. These proteins are what gives this virus its personality, if you will, gives it its structure or its profile as we think about trying to come up with potentials for vaccine candidates. So these proteins that are expressed, there's variation within that, and we see all sorts of combinations with the assortment of those amino acids that we in turn have the potential to produce vaccine and to mount an immune response against, right? They also lend to the virus itself. It lends to enhancing the ability for it to recognize and dock with specific cells and penetrate in. Oh yeah, sorry. I don't want to shift over there yet. Hang on one second. Let me stop this and share this real quick. Okay, give everything a second to get on there. Okay, so you should be seeing this table coming out of the text. What is it? Table 22.2. And these, I have tried copying a couple of these into the PowerPoints, and they always give me some issues with formatting once I try to do that. I don't know why. So, like I said, a comparison between the cold and influenza. There are some similarities, but ultimately, if you have the flu or have had the flu, you recognize that it's considerably more severe. So there's the potential for fever with both. Oftentimes, the common cold, it's classified really as a low-grade fever, very minor. With the flu, it's definitely more pronounced. Both, you see issues with headache. There's aches and pains, but with the common cold, it's definitely more mild. A little bit of fatigue with the cold, and in both circumstances with the flu, you're bedridden pretty much. You're wiped out. Congestion and sneezing are more common, definitely, with the common cold, and very rare with influenza. So there is definitely some variation between the two. And like I said, there's different strains of influenza that sets the stage maybe for increasing some of the severity with this. And there are numerous strains and different types of virus that we classify as culprits for the common cold. And with all of those guys, symptoms are really pretty similar, right? So with that said, thinking a little bit about that, right, as you're paying attention to the tables that I told you are important to think about as we move through all of these chapters, symptoms are things you want to look at a little bit, but you also want to kind of recognize that oftentimes symptoms that we're seeing with, similar pulmonary tract infections or whatever, you're going to see a lot of commonality. So those may not necessarily be the main idea that you want to be focusing on. More this type of organism, this body site, and then a little bit of the symptoms that allows you to recognize some commonalities or potentially some key differences that may set it apart. As we look at here, some of these things definitely indicate differences, right, based off of patients' symptoms as we start thinking some of those details. Looks like I've got a chat up here. Let me see real quick. So I think I just answered that. I hope I answered that as far as the specifics with those tables. And you will see here in 1 second. Let me stop sharing this and get back to the text or to the PowerPoint. We will so many buttons to click. We'll see a table here in a second, and I'll shed some more light on that here in 1 second. Okay. Maybe. Okay, so back to the flu. We're going to skip past that. There are definitely some other details with this. I guess I can mention real briefly. Influenza is an RNA virus, and the potential for RNA virus to mutate is considerably more than a virus that's DNA based because of the RNA polymerase lacking proofreading mechanisms. It sets the stage for seeing all sorts of variation with the different types of virus, and that sets the stage also for potentially seeing some strains that are considerably more virulent. That depends on levels of mutation that have occurred and potentially reassortment of a recombination of some virus if you happen to be fortunate enough to be co-infected with two strains. You might ship out something that's completely different than either of the two that really were causing your illness in the first place. And that in turn sets the stage for enhancing, some of the virulence, as I was mentioning. So shifting over a little bit, we're still focusing on virus. Measles, this first one is true measles, rubeola. These present, and these are, lots of the viral things that we start moving through. We think about a lot of the potentials for vaccination to prevent this from happening in the first place. So flu vaccines, measles vaccines, all setting the stage to eliminate the potential of having to go through this in the first place. And there are all sorts, issues as we think about vaccine, whether you're on board or not, right? I hope you're on board. Vaccination truly is critical, but there are definitely some issues as we see these things not causing big impacts, so people don't recognize how severe it truly was back in the day, if you will. And so they become very lax with that and think, well, it's not really that important. But if you were to go back a handful of decades when we see these as serious disease, well, that might be a different story. So whatever. They typically, measles present as raised macular rash, starts up on the face, and then it spreads to the extremities. There's potential up in the mouth, the Koplik spots, as the virus, manifests throughout the body. And here's an image of one of the viral particles. This is kind of a cousin. This is German measles, rubella. It is much more mild, right? There's still potential issues for sure, but here you can see the rash. Let's flip back and wrong way. Back and forth a little bit. You can see there is a little bit of similarity. This is less pronounced, so not as intense. And lesions aren't confluent, so they're not merging and forming larger lesions. And then here's a micrograph of those guys. Chickenpox lesions here. These are things that depends on your age, something that you've potentially experienced, or maybe you've been vaccinated against, and in turn, not dealing with that. There are, all sorts of ideas with chickenpox. It is a highly contagious virus. Just coming in contact with someone that has it, if you had not had it or been vaccinated, the likelihood of you contracting chickenpox was very high. So something that typically plagued little kids. Parents oftentimes hoped that if you're, before vaccination, hoped that if you were going to contract it, it was, when school was not in session, because you were going to be out of commission for a bit of time, maybe a week or so of feeling pretty bad. So there were definitely potentials for parents to have, they find out one kid on the block's got chickenpox, all of a sudden play date, and everybody's over at that kid's house. He feels like crap, and you wonder, why did we come over here to play? You came over here to get infected, right? Deep down, stinking parents. That's what it was all about. And then you spend the next week of summer vacation laying around, not scratching when your mom's in the room, right? And then back to, those suckers itch terribly. So there are definitely situations with this where we think you get one bout of chickenpox and you're all fine and good, but there are circumstances where maybe you're young, you contract it, but you don't mount a big outbreak really. And you're kind of primed for another encounter. There's definitely potentials for that. I recall, when I was young, I think I was about kindergarten when I had chicken pox. I have a younger sister. She's a couple of years younger than me. I had it. She got chicken pox. She got one, right? That doesn't count. That is not chicken pox, right? It's chicken pox. Doesn't count. So she had one pox, and a couple of years later, she got chicken pox, basically, right around kindergarten time. She got it, and she had much more than one pox. And then, like, oh, I'm glad, right? Because you can't get off with just one. That's not fair. But typically, once you get it, we think about immunity, if you will. All right. We'll see. I think it's the next image. If not, it's in here in just a couple of slides. There are potentials for later this virus, and there are numbers of viral culprits that can go dormant or take up residence on maybe some nerve cells, and they can flare back up. They can reemerge later on, and chickenpox virus definitely can do that later on, showing up as shingles. The lesions look different. They manifest definitely differently, and there's considerable pain as this starts to reemerge off of those specific nerves that they've taken up residence on. You see definitely some issues with that. So it's human herpes virus 3, varicella zoster is what we call it, but it is a type of herpes virus. And here is the shingles. Like I said, typically, not always, but typically this is something that happens later on. So you've had chicken pox as a little kid, and then you hit, 60s or 70s, and numerous things kind of start happening. Immunity starts to wane. There are all sorts of potentials for things to kind of start plaguing you that maybe you were keeping under control before. So there are vaccines, shingles vaccines that they recommend for people, I think right as you turn 60, where they recommend you start getting the vaccine to prevent this from, well, flaring up, I guess we could say. So that's the idea. And here, kind of a blow up, but these lesions are different. There's some similarity to the chickenpox, but not exactly the same. There are definitely issues with this. And again, vaccine has really kind of driven a wedge in chickenpox, but there are potentials. If you're little, you haven't been vaccinated, and you come in contact with someone with shingles, potentially grandparent has shingles, you're in contact with that person, almost guaranteed you will develop chickenpox, right? There are other situations where parents vaccinate their children against chickenpox, and then their child develops it. And this all goes back to immunity that we were talking about before. Just because you got the vaccine doesn't mean that right after that needle is removed from your arm, you're protected. It takes time to mount an immune response. So these kids could have potentially already been exposed right before they were inoculated, or they got exposed shortly after the chickenpox vaccine, and then they developed it, right? So the vaccine is effective. It just depends kind of on this window of time. And that really it holds for anything that we start thinking about utilizing vaccines for. Okay. This one, I'm going to shift out of here real quick and move back to the textbook, because that table is not, can't see anything on that. All right, let me move on down. Here's some as I've got it on here, some outbreaks of flu that we can see. So this Spanish flu, H1N1, back in the day, 1918, 1919, this was a pandemic. And it was definitely a serious situation. We could see millions of people dying from the flu. There are people, you can check out the cemetery around here or anywhere where you're from and go back and look at some of the dates and, speculate. Are these graves from clear back in the day from 1918? Did they die of the flu? Potentially, all right? Kind of crazy. So you can see a couple of other outbreaks, the Asian and the Hong Kong flu. Swine flu in 2009 was the same as the bad one in 1918. And we were very concerned that there were going to be issues similar to this, but as it turned out, it was not as virulent. Although the profile on here was the same, it was not exactly the same as what we had initially dealt with, and the deaths were far, far less, right? So kind of interesting with that. So moving on down, I know that table's coming up. Okay. So with this, you can see, move it more to the middle, probably doesn't matter, but in the room, it's better if it's centered. So the specific disease, its respective pathogens. So as I said, it's varicella zoster. It is a type of herpes, but varicella zoster is really what you want to think. That, chickenpox, all right? Common cold, we mentioned it. We didn't show any images, but there's a handful of different viral culprits: rhinovirus, adenoviruses, and coronaviruses. Not the coronavirus we're dealing with right now, but similar cousins, if you will. All right, and you can see vaccines over here in the last column. We want to think a little bit about that. Are there potential vaccines or not? Many, as I said. We do see vaccines against. Where we've got numerous culprits for the common cold, very hard to develop something that targets everything. Almost impossible. I don't know if they even are thinking about trying to find a vaccine for that. Definitely hoping for something with influenza, because the potential for it to be considerably more severe is there, right? And every year we see strains that cause deaths, and some years considerably more. Measles, as we showed, it is a very contagious virus, and the MMR, measles, mumps, and rubella, the German measles, are within this vaccine schedule right here. MERS is the Middle East Respiratory Syndrome, a coronavirus similar to what we're looking at today, not exact, all right? So another respiratory secretion. The German measles we've mentioned, we saw some images, and again, the R in that. SARS-CoV right here, which is really what we're thinking about, similar to the pandemic that we're in right now, a type of this, a variant. So respiratory secretions, hence the masks, are critical in trying to drive a wedge in that, because definitely concerns, as you all know, with the majority of you tuning in from home. So shingles again, varicella zoster, I've scrolled down, but you'd see it's the exact same player as it was up above. And so a little bit different, hitting you later on. And then the vaccine, herpes zoster or shingles vaccine, it's not the exact same as chickenpox vaccine. And then viral pneumonia, handful of different viruses that can cause this. Also sort of sets the stage for, depending upon how old you are, RSV, respiratory syncytial virus, is something that's super common in little kids. You hit older, not so much. You start thinking some of the others, all right? Can be mild cold-like symptoms to super severe if we're thinking RSV with the little kids. Okay, stop sharing that. Okay, so shifting from the virus, this is good stuff. It's also maybe kind of disturbing. We want to think about some fungal stuff as we shift over the littlest bit. And there's going to be some protists in here too. I can't remember if we slam them all together or if we get them separated. So this first one is a type of fungal organism, Coccidioides immitis. There's a couple of other species of these guys, but immitis is one of the main ones we think about, all right? This is something that, you know, there's a handful of dimorphic fungal infections. We'll see a couple in here. I feel like we're pretty fortunate to live in Idaho. We don't see these things, right? There are definitely some thoughts as we think, you know, climate change, the potential for some of these things maybe to decide this is an okay location. It's definitely in the back of my mind, all right? So Coccidioides, this is something that we think of as more like Southwest California, Southern California is definitely a potential for this. Sometimes they call it valley fever for the San Joaquin Valley. Definitely an area where we would find this fungus endemic, so normally present or found there. Dependent upon circumstances, wildfire, where you've got winds being generated, potentially can set the stage for this to be moved and transmitted because it is aerosolized and you inhale the spores. The winds, the Santa Ana winds, blowing dust definitely increases the likelihood during that time of the year for you to become infected. There's definitely situations with some of these guys with people that you'd classify as snowbirds that live in more of a northern environment and they head to the south in the winter months. There they spend their time, maybe out on the golf course, potentially coming in contact with these guys, and then they travel back to wherever, to areas where this is not on the radar, and it sets the stage for issues. I can tell you that some clinics in Canada are definitely thinking more about this now as a result of all of the people traveling down to Arizona, California, in the winter months. So here's a micrograph where we can see the spores fluorescing. These are not the same types of endospores thinking bacteria, all right? This is different. These are reproductive spores, not resting bodies to withstand some environmental issues, all right? This is a structure that would be reproductive, all right? So spheral would be this big sac, and inside of it, these spores, endospores, that as it's released will go on and continue to infect more cells. So what we're looking at on the top, this guy, typically Coccidioides and the dimorphic fungi for that matter, initiate in the lungs. You inhale the fungus, it typically converts into a yeast phase or the spheral phase, which is really kind of like a yeast cell. And they proliferate within the pulmonary tissue, within the alveoli. They potentially get to the point that they can disseminate. So breaking out of the lungs into the circulatory system usually sets the stage for them to be able to move throughout the body. And in this case, manifesting on the face, skin lesions. With a handful of these dimorphic fungi, this might be the first instance that you've got stuff going on. And by the time you've got lesions on your skin, you're in super poor shape. This infection's been going on for quite some time. So definitely an issue. This, when I first was scrolling through here, I'm like, Legionella, this is out of place, but it's not. we're not now not talking fungi, but we do have a protist here, some amoeba. And amoeba, they like moist environments. They like aquatic environments most of the time. And with that said, our Legionella that we mentioned before, Legionella pneumophila, has definite issues to cause pulmonary infection. Uh, these organisms can take up residence inside of amoeba and potentially allowing them to survive and withstand maybe periods of adversity, something that might not be so good for that bacterium, but the amoeba sets the stage for lending to their survival. So it shows, here infecting the amoeba, I think they potentially can cohabitate and maybe have a mutualistic relationship. I'm not 100%. I don't think the bacteria kills the amoeba, all right? And I don't think the amoeba kills the bacterium by, either way. So mutualism, kind of interesting. And there's a whole bunch of these little Legionella bacteria inside of the amoeba, right? Kind of crazy looking. All right, so does seem, that figure sort of out of place because now we're right back to fungus. This next image is blastomycosis. Blastomyces dermatitidis right here is the fungal organism. And it's another dimorphic fungus. It grows in the environment as a mold. It releases spores. And if those spores happen to be inhaled within the lungs, within a nice warm environment, they convert into these yeast cells. And they've got a very thick cell wall made up of chitin. And you can see this as it's surrounding. There's a couple of them in the process of replicating. They reproduce asexually by budding. And so we've got some of those images. Similarly as the coccidioides starting off in the lungs, then potentially disseminating, proliferating throughout the body. And in this case, we can see this individual's hand that's got some serious infection. And as I look at all of these images of dimorphic fungi, it really makes me think of these individuals molding from the inside out is really kind of how it looks. All right. It's not mold at this point, it's yeast. All right. But that's kind of how it appears. All right. It's kind of like they're rotting, they're spoiling. All right. What the heck? That is crazy stuff. All right. So I think it's really pretty interesting, but yeah, we will leave this. I will tell you, it always excites me as I see blastomycosis. As a graduate student, this was the organism that I studied, and I studied aspects of it from an immunological standpoint, thinking about how our body potentially can respond or maybe doesn't respond, and possible ways to detect. So looking at antibody production or antigen from the organism to detect with respective antibodies. That's kind of my focus. So in turn, these guys, coccidioides and histoplasma, they are the three big dimorphic fungi, and there's some similar issues as far as cutaneous manifestations and some differences as far as locations where you might find them. So this next one, a little bit different, and this is mold. This is a fungus ball, which I think is kind of gross. It makes me think of a cat hacking up a hairball. That's kind of what it makes me think of. So instead of a hairball, this is a big glob of fungus within your lungs. So that's what we're circling in right here, for it's all kind of occluded in the radiograph. This is a bunch of fungus that's taken up residence and proliferated within the lungs. So aspergillus is the fungus. Aspergilloma is the fungus ball that we can see in the radiograph. This is something I think we mentioned before, black mold, issues with that, like sick building and other stuff. So inhalation of those fungal spores sets the stage maybe for some of this to occur. And it's especially more important if we think about situations where maybe your immune response isn't competent. That might lend to these guys having a greater likelihood of taking hold and proliferating. These next ones, these are a type of fungi. These are some yeast cells, pneumocystis, Jerebeckii. They are interesting. They have, definitely issues in the pulmonary tract, but it's something that typically isn't seen. All right. Lots of us potentially may, you might come in contact, but they don't manifest. They can't get in and take hold. It's only truly if you've got a serious infection that debilitates your immune response, something like HIV. And it's really as HIV is progressing to the point that we now want to classify it as AIDS, when your immune response has been basically wiped out, it opens up the door for all sorts of things to start plaguing you. And pneumocystis is super, super common in AIDS patients. They typically are infected with numerous types of things that, again, oftentimes aren't a huge concern to us. All right. If we're healthy, we don't even recognize that we've, been exposed. But you turn the page to those individuals, and now all of a sudden they take hold and you see big problems. So this could be thought of as kind of a red flag. Someone that you see that's contracted this, you want some further details about what's going on with their health status. Let me see here. Looks like I got a chat up here. Oh, I know, right here. The final is only over this last material. So it only covers what we're hitting right now. It is worth more points because there are so many organisms. There will be more questions, twice as many points. Okay, so Cryptococcus, this guy also yeast cell. Cryptococcus neoformans is the organism. This is something that is also common in individuals that have progressed to the state of AIDS. So here we've got a negative stain with these guys. So we don't do this in the lab, but we've talked about it before, where you use the India ink to stain the slide or the background. And then you can see these yeast cells, and the halos around them are the huge or the super thick capsule layers that these guys are producing. They are awesome when we think about capsule stains, right? Not awesome if they're coming out of your lungs, right? But looking at them microscopically, they are definitely impressive. So the one that's actually colored, we've got images from the lung from a patient with Cryptococcus and HIV. And you can see the dark cells are the Cryptococcus. Again, the chitinous layer, they stain, very dark with that. Okay. Let me stop this. Let me move back. Okay. Here we can see as far as treatment with the fungi, there's a lot of different drugs. You don't need to know all of these names of the drugs. There's a lot of azole drugs, as we see here, something azole, and amphotericin. These are some of the standards, and all of these azoles are just molecularly tweaked the littlest bit. Doesn't matter, all right? A lot of the treatments are kind of similar. With that said, fungal infections definitely are more of a concern when we think about treatment. because they are eukaryotic cells, just like our own cells. It's more of an issue trying to combat them. And it's also more of an issue really trying to get at them in the first place. So it's not like a 2-week course of antibiotics to kill a bacterium. We're thinking months, right? Potentially longer, maybe even a year that you're trying to treat this infection, right? And that also sets the stage for other problems, drug interactions. Some of these things cause serious issues. And so careful monitoring of the patient is definitely critical to ensure that they're responding favorably and aren't getting, some adverse effect, liver damage or kidney damage for some of these drugs. So aspergillosis with aspergillus, oftentimes we can see, maybe chest x-ray to show us something's going on, but it's not going to be diagnostic. And then there's other immunological techniques, as we can see with some of these other things, trying to detect specifics. So the blastomycosis, blastomyces dermatitidis, again, there's numerous things that are kind of similar. It's pulmonary and potential to disseminate, or maybe some of these guys like Cryptococcus just stand within the lungs. Same with aspergillosis. Coccidioidomycosis, we saw an image of this. Crypto, we also saw the histoplasmosis. We talked about that in one of the earlier chapters, maybe when we were talking fungi in the first unit of material, we saw a little of this stuff. There's definitely associations with histoplasma and feces like bats or birds, but typically bats are more common with that. And so coming in contact with that type of an environment does increase your likelihood of possibly contracting it. The Cryptococcus, these guys, also feces, but it's more bird, pigeons especially, and pigeon feces definitely sets the stage for some issues with this. Again, compromised individuals are more likely for this to really manifest, all right? If feeding pigeons is your pastime, you don't need to stop, all right? Mucormycosis, sorry, that's a mouthful. There's a handful of different fungi, Rhizopus, a couple of species of Rhizopus and Mucor. Some of these are really, I'd classify as pretty common for us to encounter. Bread molds, Rhizopus is a pretty good bread mold. I guess Mucor probably can be bread mold too. Pretty stinking common, all right? And, I don't want to gross you out, but I'm going to. Taking a mycology class, learning about all of the different types of fungi. This one is something that just flat out disturbed me. I am willing to wager every one of us, unless you've got celiac disease and you've never seen a loaf of bread in your life, most all of us have had a loaf of bread that's got a little mold in there. And I hope you see that, you throw it away. But oftentimes you open it up, you're pulling the bread out. That's when you recognize there's some mold on there. That's potentially an issue, right? Individuals that are compromised, they're the ones that are definitely a greater risk with this. Normal individuals, competent immune response, that moldy loaf of bread's not going to do you in. But the people that do have a weakened or a non-existent immune response, simply opening that loaf of bread, inhaling a few of those fungal spores, maybe within 48 hours, we're doing an autopsy, all right? Maybe it's a little bit later, all right? How did they die? The fungus got into them, into their brain, and that's the end, all right? Awesome, right? Or disturbing, right? So there's definitely some issues with this. And as we say right here, often fatal, all right? Again, compromised situations are really more of the circumstance with that, right? So you've all, like I said, probably seen some moldy bread. I mentioned this was years ago. I mentioned a little bit about this. And I think actually it was just in a biology class, not in micro. And a student raised his hand and said, I have a friend. And that makes me think it's really him. But I have a friend. He saves his bread till it gets moldy. Then he makes sandwiches because he likes the way it tastes. That's gross, right? But whatever, right? Maybe it's building some immunity. I don't know. All right, pneumocystis, the last one. We'll quit right after this. Pneumocystis jirovecii, pneumocystis pneumonia. Again, another one where we're thinking compromised situation with that. All right. Stop that. Any questions or concerns before we get this ended? Okay, guys, I hope you all have a great weekend.